Okay, starting the new system nephrology for MRCP part 1. Okay, the things that we need to know for MRCP part 1, these are the notes, not like the details. So yeah, starting with physiology and basics, things that we need to know is firstly renin-angiotensin aldosterone system, RAAS, as we all know. Adrenal cortex produces the following. There's a mnemonic for that, that is GFR-ACT. GFR is basically zona glomerulosa on the outside, mainly produces aldosterone, zona fasciculata in the middle produces cortisol, glucocorticoid, reticularis mainly produces androgens, mainly dehydroepiandrosterone, DHEA. So adrenal cortex mnemonic is GFR-ACT. So what's renin now? Renin released by juxtaglomerular cells in the kidney in response to decreased renal perfusion or by decreased sodium. So when the blood pressure decreases, renal perfusion decreases, so renin is produced then. It hydrolyzes angiotensinogen to form angiotensin 1, and then the RAS process starts. The factors that increases renin secretion is low BP, low renal perfusion, as I've said before, hyponatremia, sympathetic nerve stimulation, catecholamine, erect posture. All these things would be increasing renin secretion. Factors that decrease renin secretion: beta blockers, NSAIDs. And angiotensin, what is it? It's ACE in lung. This is from the lungs, converts angiotensin 1 to angiotensin 2. It mainly causes vasoconstrictions leading to raised BP, stimulates thirst, stimulates aldosterone and ADH release. So a very important thing. This both will be causing water to be retained, especially ADH causes water to retain in the body. Aldosterone, what does it do? Released by the zona glomerulosa, as mentioned above here. Aldosterone released by the zona glomerulosa to raise, in response to raised angiotensin 2, potassium and ACTH levels. So in response to these three, aldosterone is produced. Causes retention of sodium in exchange for potassium and hydrogen in the distal tubule. Okay. Next is urinalysis. In the analysis of urine, firstly, condition normal. Findings like few RBC, normal morphology, fine granular cast or hyaline cast. In glomerular disease, we find dysmorphic red blood cells. In UTI and pyelonephritis, that is white blood cell and white cell cast. In glomerular nephritis, red cell cast. ADH is secreted from the posterior pituitary gland, as we all know. It promotes water area absorption in the collecting ducts of the kidney by the insertion of aquaporin tool channels. Okay, basic problems in the CKD. So CKD is chronic kidney disease, and we know that CKD will have a lot of repercussions. Firstly, lack of vitamin D will be there. Alpha-1 and hydroxylation occurs in kidneys, so lack of vitamin D. Increased phosphate due to less excretion, since phosphate is usually going out of kidney. In CKD, phosphate will stay in the blood. Lack of calcium due to lack of vitamin D and increased phosphate. Secondary hyperparathyroidism due to low calcium, increased phosphate and increased vitamin D. Okay, several clinical manifestations may result. Osteitis fibrosa cystica, also known as hyperparathyroid bone disease. So calcium is decreasing, there will be like a lot of bone fractures. A dynamic reduction in cellular activity, both osteoblasts and osteoclasts in the bones, maybe due to over-treatment of vitamin D. Osteomalacia due to low vitamin D, osteosclerosis, osteoporosis. So this picture gives a rough idea about what happens. Classification of CKD, there are stages like stage 1, eGFR is more than 90, and stage 2, 60 to 89, 3A, 45 to 59, 3B, 30 to 44, 4, 15 to 29, 5, less than 15. So 1 and 2, in order to diagnose stage 1 and 2, additional evidence of kidney damage must be present, like proteinuria. You have to check protein in urine. And 3A, 3B, moderately lower GFR, severely lower GFR. Patients on dialysis are classified as stage 5D. Okay, so the suffix T indicates patients with a functioning renal transplant can be stage 1 to 5. With proteinuria, 24 hour more than 1 gram per day, or urine PCR more than 100, so as present, the suffix P may be added. So moving on to the proteinuria topic. Proteinuria is an important marker of CKD, especially for diabetic nephropathy. NICE 2020 recommends using the urinary serum creatinine, EGFR, and ACR, very important, to monitor urine function. To assess the rate of progression, repeat the EGFR 3 times over at least 3 months. By collecting and interpreting ACR, by collecting a spot sample, it avoids the need to collect urine over 24-hour period in order to detect or quantify proteinuria. Important. Should be first pass morning urine specimen. ACR more than 3 mg per millimole is clinically important proteinuria. So this is very important, like the values. If the initial ACR is between 3 and 70 mg per millimole, confirmed by consequent early morning sample. If initial ACR is more than 70, this confirms proteinuria and requires referral to nephrologist. Management for proteinuria would be ACE inhibitor or ARBs. Diabetes. Patient with diabetes and proteinuria, prescribe ACE inhibitor or ARB if ACR is more than 3 or equal to 3. Target systolic BP should be less than 130. If there is hypertension, prescribe ACE inhibitor or ARB if ACR is more than 30, not 3. So diabetes is more dangerous. ACR less than or equal to 70, SBP should be less than 140. If it's more, then SBP should be lesser. ACR more than 30 plus persistent hematuria after exclusion of UTI. Refer to nephrologist. So this section is for hypertension. When do you refer to nephrologist? Is basically ACR more than 30 and persistent hematuria after exclusion of UTI. ACR more than 70 unless known DM nephropathy. EGFR less than 30. Renal anemia after exclusion of iron deficiency. Anemia and CKD. So anemia and CKD. Investigate and manage anemia and CKD if hemoglobin is less than 110, that is less than 11. Investigate iron deficiency and determine potential responsiveness to iron therapy and long-term iron requirement every 3 months using hypochromic or red blood cell HRC more than 6%, reticulocyte hemoglobin count or equivalent test. Do not request transparent SAT or serum ferritin measurement alone to assess iron deficiency in CKD. Could only be used in thalassemia. Do not routinely measure EPO levels for the diagnosis or management. If not on dialysis, a trial of oral iron before offering iron IV. If they are intolerant of oral iron or target hemoglobins are not reached within 3 months, offer IV. So this is very important. If the patient is not on dialysis, you should just try for oral iron at first, and if it doesn't work, then go for IV. No need to go for IV at first. If on hemodialysis, offer IV iron therapy. Maintain hemoglobin range between 100 to 120. So this is 10 to 12. ESA, erythropoietic stimulating agent, should not be initiated in the presence of absolute iron deficiency without managing the iron deficiency. So manage iron deficiency first and then EPO. Monitor hemoglobin in 2 to 4 weeks after initiation. Avoid blood transfusion where possible, when kidney transplant is a treatment option. Adjust ESA to keep the rate of hemoglobin increase between 10 to 20 gram per liter per month. Offer patients receiving erythropoietic stimulating agent iron therapy to achieve percentage of hypochromic red blood cell less than 6%, unless ferritin is more than 800 microgram, reticulocyte hemoglobin count or equivalent test more than 29. Consider referring people with ESA resistance to a hematology service, particularly if an underlying hematological disorder is suspected. Correction to normal levels of hemoglobin with ESA is not recommended. Using ESA to achieve hemoglobin more than 120 is associated with increased risk of death and in serious cardiovascular events in people with CKD. So these are some points you need to remember. Next would be erythropoietin. It's another important factor. Erythropoietin is a hematopoietic growth factor that stimulates the production of erythrocytes. The main use of erythropoietin are to treat the anemia associated with chronic renal failure and that associated with cytotoxic therapy. But there are many side effects of erythropoietin. Side effects firstly would be hypertension and hypertension crisis, potentially, encephalopathy and seizures. BP would increase in 25% of the patients. EPO induced seizures occurs after 90 days from starting the treatment, so 90 days would be important. Bone aches, flu-like symptoms, skin rashes, urticaria, pure red cell aplasia due to antibodies against erythropoietin, raised packed cell volume, PCV, hematocrit, increased risk of thrombosis, fistula, iron deficiency secondary to increased erythropoiesis. There are several reasons why patient may fail to respond to erythropoietin therapy. That's what they said before. To correct the iron therapy first before giving erythropoietin. Inadequate dose, concurrent infection or inflammation, hyperparathyroid, bone disease, aluminium toxicity, malignancy in particular myeloma. EPO can be detected in urine for first few weeks after the latest dose. Indication for urgent dialysis. What are the indications for urgent dialysis? This is something we have studied over time. Severe acidosis, pulmonary edema due to volume overload, hyperkalemia, uremic pericarditis, encephalopathy, vomiting, uremic symptoms. These are. Let's move on to the next topic. Sterile pyuria, broadly defined as the presence of leukocytes in the urine in the absence of demonstrable urinary tract infection. Basically, there are leukocytes, but there are not proper organism. So sterile pyuria can happen if previously treated partially treated UTI is there. Urethritis with chlamydia, TB, and uroplasma ureolyticum, renal TB, renal stones, appendicitis, bladder or renal cell cancer, APKD, analgesic nephropathy, tubulointerstitial nephritis may cause sterile pyuria, not seen with acute glomerulonephritis. So these are the causes of sterile pyuria. Next comes renal vascular disease. Renal vascular disease is mostly due to atherosclerosis. Of now, more than 95% of the patient is associated with CV risk factors such as smoking and hypertension, cardiovascular risk factors. Presentation might be hypertension, chronic renal failure, flash pulmonary edema. In younger patients, fibromuscular dysplasia needs to be considered. MR angiography is now the investigation of choice. CT angiography, conventional renal angiography is less commonly performed nowadays, but may still have a role when planning surgery. Flash pulmonary edema, urea and electrolytes worse on ACE inhibitor, asymmetrical kidneys, maybe renal artery stenosis is the cause. Do MR angiography. So FMD, fibromuscular dysplasia, is more common in young women and characteristically has a string of beads appearance on the renal angiography. Patients respond well to balloon angioplasty. Hyperkalemia and metabolic alkalosis may occur due to compensatory hyperaldosteronism. Alright, next move on to the next part, hematuria. The terminology hematuria surrounding hematuria is changing. Microscopic or dipstick positive hematuria is increasingly termed non-visible hematuria, while macroscopic hematuria is termed visible hematuria. Causes of transient non-visible hematuria and causes of persistent non-visible. So for a while, there can be non-visible hematuria like UTI, menstruation because excited sexual intercourse, and for causes of persistent non-visible hematuria would be cancer, stones, or cancer, bladder, renal, prostate, stones, BPH, urethritis, renal causes like IgA nephropathy, thin basement membrane disease. So this is something which is coming up very soon for a while. These are the other causes. Urine dipstick is the test of choice for detecting hematuria. Urine microscopy may be used, but time to analyze significantly affects the number of red blood cells detected. The incidence of non-visible hematuria is similar in patients taking aspirin or warfarin to the general population, hence these patients should also be investigated. NICE 2015 urgent cancer referral guidelines. Any age with unexplained persistent painless macroscopic hematuria, more than 45 years with recurrent or persistent UTI associated with hematuria, more than 6 years with unexplained microscopic hematuria. Cancer referral guidelines. Okay, we move on to the very important topic, that is renal disorder. Renal disorder comes up with a lot of new topics. Okay, renal disorder. Okay, firstly is nephrotic syndrome, the triad of proteinuria, more than 3 gram per day. And then there is hypoalbuminemia, less than 30 gram per liter, and edema. So these are the things that really are there for nephrotic syndrome. There will be loss of antithrombin 3. Since these are proteins going out, protein C and protein S are and associated rise in fibrinogen levels predisposed to thrombosis. So all these factors are moving out of the body. This protein moving out through nephrotic syndrome. So thrombosis might be happening, and there will be rise on fibrinogen levels. Okay, now the causes of nephrotic syndrome can be many. So firstly, there can be glomerulonephritis, minimal change glomerulonephritis, 75% of the times in children and 25% in adults. Membranous glomerulonephritis may also cause protein problem, proteinuria, nephrotic syndrome, focal segmental glomerulosclerosis. So these three are like totally that you need to know. It's nephrotic syndrome. Like all these diseases, all this type of glomerulonephritis is present with nephrotic syndrome. Minimal change disease that occurs mostly in children, membranous glomerulonephritis, focal segmental glomerulosclerosis. So these things will come up again and again in the rest of the chapter. Systemic disease like amyloidosis, SLE may also show up with nephrotic syndrome. Others may be congenital neoplasia like carcinoma, lymphoma, leukemia, myeloma, infection like bacterial endocarditis, hepatitis B, malaria, renal vein thrombosis. Drugs like coal and penicillin may also cause renal disorder. What are the complications? Increases of infection due to urinary immunoglobulin loss. This is a big thing that you need to consider when talking about protein loss. Like immunoglobulins are also proteins, and they also get lost by the urine flow, and thus there is increases of infection. There's increases of thromboembolism related to loss of antithrombin 3, protein C and S, and plasminogen in the urine. Hyperlipidemia, hypocalcemia, vitamin D and P binding protein loss in urine. So this is also important. All the proteins that are there which binds to things, they go away, and so hypocalcemia. Acute renal failure could be due to thrombotic renal veins. It comes with low and hematuria. Thrombotic renal vein. So since it's more likely to have thrombosis, thrombotic renal vein comes with low and hematuria. Now we're talking about glomerulonephritis. Generally classified according to the histopathology. The histopathologic appearance can be characterized according to presentation. Okay, now there's 3 types of presentation in glomerulonephritis. We just talked about the nephrotic presentation, but let's see the other ones. One is nephrotic presentation. The number 2 would be mild glomerulonephritic presentation, nephritic, which involves a lot of hematuria and stuff. Rapidly progressive glomerulonephritis presentation. So this is much more like acute and stuff. So post-transplant recurrence of original renal disease, IgA more than FSGS, more than membranous, more than membranous proliferative. Post-transplant recurrence. IgA nephropathy would be the number 1 cause. Okay, now nephrotic presentation. Again, we'll go to those 3. We've seen here glomerulonephritis, nephrotic presentation, minimal change, membranous, FSGS. So we'll go on to details, and it will be again coming back in details, so don't worry. If you don't understand once, you go back to it again and again, it will be inside your head for sure. Okay, the first one is minimal change. This is, as I've said, typically a child with nephrotic syndrome accounts for 80%. So remember, this is nephrotic. Causes might be Hodgkin's syndrome, NSA. It's good response to steroids. It's important. Steroids might help the children with minimal change disease. Next is FSGS. Something I try to remember is for FSGS, it's like transplant and HIV, heroin, all these things. Maybe idiopathic primary presentation might be, of course, proteinuria, nephrotic syndrome, CRF. Less responsive to steroids can occur after transplant. So it's something you need to remember. Transplant, high recurrence rate in renal transplant. So transplant equals to from focal segmental glomerulosclerosis. Secondary to this is like primary causes. Secondary to HIV, heroin, Alport syndrome, sickle cell anemia, morbid obesity, or chronic hypertension. Presence with variable proteinuria and outcome. Okay, membranous glomerulonephritis, a common cause of adult idiopathic nephrotic syndrome. Membranous glomerulonephritis. So this is like the other one, third one. You just have to remember nephrotic would be number one, minimal change disease. Number two, FSGS. And number three would be membranous. So these three you have to remember. Membranous glomerulonephritis, common cause of adult idiopathic nephrotic syndrome. So for the kids, it will be minimal change. For adults, membranous glomerulonephritis. Presentation is proteinuria, nephrotic syndrome, CRF, similar to that. Cause would be hepatitis B, rheumatoid drugs like penicillamine, NSAIDs, malignancy. Immune deposits. What do you find actually in the glomerulus? Like immune deposits will be there. Glomerular epithelial, subepithelial IgG. 1/3 of the cases resolve, 1/3 respond to cytotoxics, 1/3 develop chronic renal failure. So you have to remember all these things, like the causes as well, like infections, hepatitis B. This is important for this. Also malignancy. Next we'll be going to its glomerulonephritic presentation. Okay, so all of the things will be coming back again, so it's like going back and back, and once you're done with it, you'll understand the whole story. It's very easy, but might seem a bit difficult at first. Okay, next is IgA nephropathy. So this is more like glomerulonephritic presentation. There is hematuria and less of proteinuria. So IgA nephropathy, also known as aka Burgess disease, messenger proliferative glomerulonephritis. So all these are the same thing. Typically young adult with hematuria following upper respiratory tract infection, Levy disease or celiac disease. Associated with henox-Conley purpura, mesangial hypercellularity, messenger proliferative. That's why it's called that. Immune deposits will be mesangial IgA, as hence the name, and C3 deposits. Okay, and this is just, again, it's not in details. The details is coming later on. This is just like, again, a classification, like glomerulonephritic presentation. The first one was glomerulonephrotic. This one, these three. The next is nephritic, so IgA nephropathy, and these names are even more confusing. Messenger proliferative, membranoproliferative. These things only will make you confused. And then messenger capillary. The second one is messenger capillary glomerulonephritis. So what happened? This is membranoproliferative, is the same thing. Immunoglobulin type, complement type. So there are two types of messenger capillary glomerulonephritis. What is immunoglobulin type? Most common pattern found in association with subacute bacterial infection, also with cryoglobulinemia and hepatitis C. So C, remember that, associated with C4, low C4. Okay, and complement type would be partial lipodystrophy associated with low C4, C3. So yeah, all these have to be recalled. But they are coming back again, so don't worry. Okay, next thing would be, we said three ways of presentation. One is nephrotic, one is nephritic, and the other one is rapidly progressive glomerulonephritis. So RPGN, that is. So what are the ones which present rapidly? Diffuse proliferative glomerulonephritis. It's classical post-streptococcal glomerulonephritis in child, present as nephritic syndrome, ARF, severe sodium and fluid retention, hypertension, hematuria, oliguria. This is like classical nephritic syndrome. Hematuria, hypertension, oliguria, and severe sodium and fluid retention. Common form of renal disease in SLE stage 4. So this is called diffuse proliferative glomerulonephritis or post-streptococcal glomerulonephritis in child. Okay. The second one, which will be rapid presentation, would be rapidly progressive RPGN glomerulonephritis. This is like focal necrotizing glomerulonephritis. Necrotizing. Rapid onset, often present as ARF. So this will be like, as the name says, rapidly progressive. So it's like rapid onset. Immune deposit, typically negative or post-immune, so we won't see much deposits. Causes include good pastures. So this has some other secondary causes, like good pasture syndrome or ANCA positive vasculitis, vagus granulomatosis. So these are like example vagus granulomatosis. So these autoimmune diseases may present with rapidly progressive glomerulonephritis. responds well to steroids and immunosuppressants. Of course, this autoimmune disease, so this will respond well to steroids and immunosuppressants. Then the third one would be anti-glomerular basement membrane disease. So this basement membrane of glomerulus, where there's antibodies made against the basement membrane. So what is there? This also presents like very acutely. Crescent glomerulonephritis, immune deposits of IgG along the baseline, associated with lung hemorrhage, but renal or lung disease may occur alone. Treatment is steroids, cyclophosphamide, and plasma exchange. So these are important. Like you have to remember the names, and it won't happen overnight. Of course, you have to revise and revise. That's all about MRCP. You have to revise a lot to remember everything. Now, disorders associated with glomerulonephritis and low serum C3. So this is again confusing because you just studied them, so remembering them is difficult. But post-streptococcal glomerulonephritis, the one we studied before, subacute bacterial endocarditis, SLE, mesenteric capillary glomerulonephritis, all these may have low C3. So go back and check which one was what. Post-streptococcal was the one with the nephritic presentation in SLE. Then the mesenteric capillary was the one, like the immunoglobulin type is low C4 and complement type low C3. Okay, let's move on to the next part. We are again back with minimal change glomerulonephritis, the one which showed nephrotic syndrome as the main feature, nearly always present as nephrotic syndrome, accounting for 75% of children and 20% of adults. Minimal change glomerulonephritis go for prednisolone. It's very good response to steroid. ACE inhibitors may be used to decrease proteinuria in patients with heavy proteinuria or who have a slow response to prednisolone. So what are the features that you see in minimal change glomerulonephritis, nephrotic syndrome? Normal tension. Hypertension is rare. It's usually a presentation of nephritis. Hematuria is very rare, as I've said. Highly selective proteinuria. So what is the star? Okay, the star is here. Only intermediate sized proteins such as albumin and transferrin leak through the glomerulus. These ones leak through the glomerulus. So what do you think will happen to serum albumin? It will be very low. Transferrin, low. Okay, causes. What are the causes of this minimal change in kids or in adults? Majority causes of cases are idiopathic. You don't know the reason, but in around 10 to 20% of causes found, like drugs, NSA, rifampicin, Hodgkin's lymphoma, NHL, and thymoma, infectious mononucleosis. Okay, so podocyte fusion is seen in minimal change glomerulonephritis. So this fusion of the podocytes, these are like feet-like projections in the glomerulus basement. So these are like this fusion of that is seen in minimal change glomerulonephritis, but may occasionally be a feature of focal segmental glomerulosclerosis as well. So both this focal segmental and minimal change, both of them present with proteinuria, so they have a similar sort of abnormality. So minimal change, however, is far more common. Okay, management. Majority of cases, 80% are steroid responsive, so of course go for steroids. Cyclophosphamide is the next step for steroid resistant cases. Prognosis is overall good, although relapse is common. Roughly 1/3 have just one episode, 2/3 have relapses. So 1/3 have infrequent relapses, 1/3 have frequent relapses which stop before adulthood. So this is it about minimal change. Okay, we're talking about membranous glomerulonephritis. Now, which one is this again? So we can forget and everything. Okay, so you can remember that nephrotic syndrome had these three: minimal change, membranous, focal segmental. So membranous is again the same one which was this again. Remember, hepatitis B, malignancy, endothelial deposit, like subepithelial IgG, 1/3 rule, that one. That is basically nephrotic syndrome in adults. That's what you need to remember. Membranous. So membranous glomerulonephritis is the commonest type of glomerulonephritis in adult, and is third most common cause of end-stage renal failure. So this is dangerous. Usually presents as nephrotic syndrome of proteinuria. So I believe you should go back and keep on reading the previous ones to recall these things better. It's important to list out and to understand which is falling under what. So these are important. So renal biopsy demonstrates. What does it demonstrate? This is for nephrotic syndrome presentation. commonest in adults. So the subepithelial immune complex, mainly IgG and C3 deposition in the glomerulus. So electron microscopy, the basement membrane is thickened with subepithelial electron deposits, IgG and C3. These are the ones which are depositing there for membranous glomerulonephritis. So what are the causes? Idiopathic infection, again, hepatitis B, malaria, malignancy, drugs like penicillamine, linacid, SLA class 5. And the rule of thirds are there is 1/3 of spontaneous remission, 1/3 remain proteinuric, and 1/3 develops ESRF. Management would be immunosuppressant, like steroids, cyclophosphamide, chlorambucil, pontinicili regime, BP control, anticoagulation. You can just do these things. Anticoagulation for what? You can understand that there will be risk of thrombosis, since all the proteins, important proteins like protein C, protein S, antithrombin 3, they're getting lost through the urine. So there's chance of thrombosis, so consider anticoagulation. Immunosuppressants like steroids, cyclophosphamide can be added as well. Okay, so that's it for video 1.